Yeah, we are live, sir. Welcome to the Indian Arthroscopy Society webinar series for the month of June. We have started this project 4 years back with Indian webinar series. We have completed around 120 webinars. After that, we have changed this into Indian Academic Corner, where expert talks along with case presentations from the junior faculty are also added to this. In this also, we have completed 40 webinars in this, and we are running towards the 50th Indian Academic Corner webinar series. Maybe we will complete end. Now, for this month webinar series moderators, Dr. Arnab Karmakar from Kolkata. Welcome you both. I would like to give the proceedings and to Dr. Arnab Karmakar and Dr. Chirag Chodasama. Over to you, sir.
Thank you. Thank you, sir. Thank you so much for giving me this honor and responsibility to conduct this Indian Arthroscopy Society webinar. So, good evening to all of our viewers. So, today, in the month of June 2024, we have gathered to discuss very interesting cases and a very good expert talk from our senior surgeon, Dr. Vikas Kapoor, sir. So, for at the first of the our webinar today, we'd like to start with our case presentation number 2 that will be presented by Dr. Ravi Babu sir, who is from Kurnool, Andhra Pradesh, and he will talk on a case that is arthroscopic PCL avulsion repair with suture bridge technique. So I would invite Dr. Ravi Babu sir to share his case and start the screen share.
Yes, sir. Good evening, sir. I am Dr. Ravi Babu, sir. I am from Kurnool, Andhra Pradesh. I am presently working at Gemcare Community Hospitals, Kurnool. It's a like a branch of Community Hospital group in big group at Hyderabad. So
So, yeah.
am I audible, sir?
Yeah, now you are audible.
Yes, sir. Yes, sir. I am Dr. Ravi Babu, sir, consultant orthoscopy surgeon at Gemcare Community Hospital, sir, Kurnool. So today my case is arthroscopic suture bridge technique from PCL TBL avulsion repair, sir. Shall I share the screen, sir?
Yes,
Yeah,
sir.
please share the slide, sir.
So I think it is visible, sir.
Yes, he is visible.
Yeah. So arthroscopic PCL tibial avulsion repair suture bridge technique. PCL avulsions, the function of PCL is to prevent the posterior translation of tibia, and the most common type is dashboard due to hyperflexion of knee. If this not treated properly, then it may lead to chronic pain, knee pain, and instability and patellar degeneration. So this is the anatomy: two bundles, anterolateral and posteromedial, PCL femoral attachment, and the tibial attachments. So these two bundles are very compact and difficult to separate at their tibial origin. And this avulsions occurs due to where patient has clinical signs with the post injuries, quadriceps active test and posterior test positive. So this is type of PCL avulsion with the tibial attachment avulsion. Uh, so and MRI is the diagnostic. T1 shows the PCL facet fracture, and we can see the displaced fragment. So this is the case where 40 years old male patient with history of dashboard injury 2 weeks back came with complaints 2 weeks old, complaints of pain, swelling, and instability right knee. On examination, posterior driver was positive, Godfrey's positive, and X-ray shows PCL tibial avulsion with minimal displacement. MRI was PCL tibial avulsion with a fragment. So this is the X-ray. Very small fragment was there. And we did MRI. MRI was showing PCL tibial avulsion. We have zoom images like this, so we can see here like, so PCL avulsed from the posterior tibial surface. So MRI showing the avulsion fragment of the PCL attachment. And so there was MCL sprain and changes in the medial meniscus. So the surgical technique usually followed is ORIF with CC screws and arthroscopic suture bridge technique. In this case, we did the arthroscopic suture bridge technique with single tunnel. So this is the conventional method where posterior approach to the through popliteal fossa and fixation of fragment. This is the suture bridge technique where we apply sutures to the PCL, take the and forms the posteriorly forms the suture bridge, and then fixation over the anterior tibia. So these are the arthroscopic suture bridge technique findings: floppy ACL sign, lax PCL, and this is like we did in three portal technique. Anterolateral is the main viewing portal. Next, anteromedial, high anteromedial portal with the posteromedial portal. So sometimes we use posterolateral. For this case, we did in three portal technique. High anteromedial portal is like to remove the synovium of the intercondylar arch and fat between the ACL and PCL. Posteromedial portal to visualize posteromedial compartment crater. So we did tibial tunnel at the fracture crater, and so we used suture bits using the fiber tape 2 mm several. So once taking the bites through the PCL, park the stitches over the posterior compartment, and then tibial tunnel made through the so by keeping the PCL jig. So after that, we removed the 4.5 mm reamer, then pass the lasso loop, and after several half hitches, take the suture bridge through the anterior tibia, make the sutures with the good traction and give anterior tibial drive, and then suture tied over the anterior tibia. So this is the fiber tape used, and this is the suture disc. So we'll go through like simple video. Did the diagnostic arthroscopy, remove the fat pad, and we can see that is the PCL lax. This is the floppy ACL sign. Uh, so when compared to normal ACL, it will be bit floppy and lax. And PCL like avulsed. If you pull it, then we did just small debridement with the RF, just removing the flaying plate tissue. After that, the synovium between the PCL and medial femoral condyle is removed, and going peeping into the posterior compartment, just driven into the posterior compartment, and then make the posteromedial portal. So with the spinal needle, we'll palpate and kept the, so did the posteromedial portal and kept the cannula. So after that, so remove the Wissinger rod and then take the bites with the fiber tape. So it's a 2 number Arthrex fiber tape. We took the bites. I think video is playing clearly, right, sir? Hello?
Yeah, it's clear.
Yes,
Absolutely
yes.
fine.
Yes, sir. Yes, sir. Yeah. So we took the bites. And then we parked the sutures into the posterior compartment and retrieved through the posteromedial portal. And then keep the jig over the posterior compartment. So sometimes the fragment is big, then we'll try to reduce with the jig only. So otherwise, if the fragment is small, then we'll just pass the bead pin and remove over the bead pin with the 4.5 mm, and then retrieve the sutures through the postro like suture lasso. So holding the bead pin and then remove the bead pin, then just do small shaver thing. After that, pass the suture lasso or suture loop. So after taking the half hitches and making the bridge, and we retrieve through the anterior tibial surface. So this is the post-op X-ray. So showing the suture disc tied over this, and the fragment is reduced over the posterior tibial surface. And few cases we did like combination of ACL reconstruction along with the PCL avulsion repair. So this is one of the case where we did ACL reconstruction, and it was a comminuted fragment. So one small piece with a bigger piece reduced over the posterior tibial surface. And another case, like we did both ACL and PCL tibial avulsion repairs in a taking suture bridge for the PCL and mini tightrope fixation for the ACL. And one case we did posterior tibial avulsion repair along the meniscal medial meniscal root repair. So we don't have X-ray. So post-op rehab, long leg knee immobilizer for like with posterior support for 3 weeks, and knee bending in prone position by after second week, and after that active knee bending by 6 weeks. So till this period, non-weight bearing for 6 weeks, with brace 3 weeks, and without brace another 3 weeks. Partial weight bearing starts at 6 weeks and progressively full weight bearing after 8 weeks. So take home message, suture bridge technique is a very good technique where we can fix the small fragments or comminuted fragment. Why? Because this will act like a ligamentotaxis, and the fragments will come and sit over the fracture surface. So for the screw fixation, we need the fragment which is 3 times bigger than the screw head. So if you're having less, the fragment is less than that three times smaller than that one, then the chance of breakage of fragment is high, chances are there. So we need the fragment which is very good, then we can fix with the screws. Otherwise, suture bridge is the very good technique, and we can do simultaneously meniscal injuries and chondral injuries can be addressed. And this is superior over, why? Because no hardware removal, and arthrofibrosis chances are also very less when compared to open procedure. But it requires some surgical skills and learning curve, as we have very narrow working space, and we are very near to the vascular bundle. So better to keep an eye, and so post-operative distal pulse monitoring. Uh, so thank you, sir.
Thank you, Dr. Ravi. It was a great presentation. So, do we have any question, Dr. Naresh? Do you have any question or any point? Yes.
Sir, my doubt is when you are using the anteromedial portal, what are the problems you faced as you are taking more posteriorly for the sake of juniors? Please explain, and what precautions you took while removing the
Posteromedial portal or anteromedial portal?
anteromedial portal, sir.
Anteromedial portal, usually we take high anteromedial portal when compared to normal. If you are using spinal needle, take the spinal needle, and better to direct like towards the PCL, between like space between the PCL or medial femoral condyle.
Okay.
So so then it's fine. So we
Mostly,
will like
mostly it is like a viewing portal. Just by removing some part of the
synovium.
medial side, you can we can directly go into the posteromedial compartment just for viewing purpose.
Yes, correct.
Okay. Right, sir.
Yeah,
And
if you are
I
like
noticed one more doubt, sir. I noticed you using the retrograde suture passing device from the anterolateral portal, it seems. Yeah. How
anterolateral
is it?
portal, no, anterolateral portal only, viewing portal only.
Okay, sir. Okay.
Yeah, we
No.
sometimes we do like
So
remove the
the
synovium
suture
between.
passing device, how you use it, the suture passing device, please explain, sir.
Yeah, that suture passing, we can take the like scorpion or like first pass mini, maybe like small diameter will be there, so we can take bites with the. So one thing is, if the space between the medial femoral condyle and PCL is good, then we can take bite in that space. And you
Okay.
can remove, like you can remove the synovium between the ACL and PCL. So that thing
Okay.
also we can take bites. Yeah.
Right. Right.
So one thing is the parking of suture into the posterior compartment and retrieving through the posteromedial compartment is bit difficult
Yeah.
step. And
Okay.
tibial posterior tibial drilling. So if the fragment is big, so
Hmm.
we'll try to reduce the fragment with the jig only, and after that
Okay.
drill the with the bead pin, and then over that 4.5 drill. So that drilling is sometimes will be difficult. Why? Because
Right.
we cannot see the bead pin. If we have like 70-degree scope, or if you like posterolateral portal, keeping the scope in the posterolateral portal and drilling will be the good.
Right. I would like to ask or add one more question to this. If the fragment is big, or if the fragment has to be reduced, and it is a old case, a proper scenario where it is old, mostly the synovium or posterior part will be attached, and there will be some attachments to the
Fibrous tissue.
uh,
Yeah.
fibrous tissue. So, to release this, any precautions you take, or what uh,
No,
suggestions you
if
give?
the if the fracture like PCL avulsion less than 3 months only, we are going for repair. If it is more than
Okay,
3 months, then we'll treat it like reconstruction will be the better option. Why?
okay,
Because less than 3 months, we did like 2 months old cases where the releasing the tissue and getting the reduction is difficult thing.
okay,
So while doing that, we use both posteromedial and posterolateral portal, and we will take
okay.
one Wisinger rod, like
Mm.
keeping over the posterior capsule, and get some space between the fragment and the posterior capsule. And also like that will give the working space, like to avoid the injury to the vascular structures,
Yeah, good, sir.
and
Good.
by keeping the cannula also. Yeah.
Right. Sharad sir, do you have any questions or any additions to this?
Um,
Please, your experience, sir.
Usually I use wire suture around the PCL, and
Okay,
I use medial and lateral instead of two posterior medial. Sometimes two
okay.
posterior medial is crowding, so I
Yes,
use medial and lateral. But this posterior medial two portals is good technique. It's a nicely done technique. It's a the only thing is same, to remove the synovium, to clear it is the issue. Otherwise, it is a standard.
oh, thank you, sir. Arnab sir,
Yeah. Okay, sir.
any
So I
additions
think
or
most
any?
things are covered. Just need to point out two things regarding my query. Is that first of all, that I have seen many of the experts just putting a luggage tag knot. They are not putting any knots over the PCL. And just according to them, if you tie too much of knot, that may hamper the vascularity of the graft. So what is your take on that? And second thing is regarding the button, because of the suture disc or whatever you are using, because it's quite big enough. And because of the holes of this suture disc are so big, it will have lot of play when you ask the patient to rehab. And we have seen many patients asking later on, they are, having an irritation under the skin because of this. So now we have stopped using this, and now we are only using either a pillar post or a small button like the endo button, because the button will be fixed and it will have very less amount of space. So these 2 points, what is your advice on this? Then we can move ahead.
Yes, sir. We use it as endo button also, sir. But using this suture pusher and keeping the suture disc more medially, and giving the incision, skin incision lower than the desired one. Why that will come with the, if you keep the jig in 60 degrees angle, and making the tunnel higher. When you compare to skin, the tunnel will be in the more proximal.
Mm-hmm. Yeah.
uh, and medially. So that may give some relief, sir. We prefer to do the incision will be somewhere, but the tunnel will be in the higher and medial.
Okay.
Yeah. So
Welcome. Dr. Chirag sir also joined.
Yeah, yeah.
Any?
So may I ask a question?
Yeah, please
yes,
go ahead, sir.
So what I found when you are using a single tunnel technique while fixing the PCL, sometimes it is difficult to control the rotation of the fragment. So what is your take on that? How do you control the rotations in single tunnel technique? The question is number one. The second question is, what amount of displacement do you accept to conserve it, or you operate in all cases of PCL avulsions? So these are the two questions for all the public for
yes,
the
sir.
understanding, right?
Yes, sir. One thing is, if the fragment is bigger, then better to do dual tunnel technique. So
Right.
take the bites and form the bridge and reduce the fragment and take like two tunnels and fix over the tibia. So that will give more stable than the single tunnel. So if the smaller fragment, then the single tunnel will be most of the times sufficient, sir. And one more thing is, if the uh, uh, second question, sir. Sorry, sir.
How
How
much
much
displacement you
displacement?
accept?
Yeah, how much displacement? So clinically, like if the patient is having posterior drawer and cartilage signs are positive, so if the displacement is more than 10 mm, so then
And
go for fixation.
the one question you said in your rehab plan, the 3 weeks non-weight bearing with brace and 3 weeks
Yes, sir.
non-weight bearing without brace. So
Correct.
what is the logic behind with brace and without brace non-weight bearing? Just I want to understand.
So first 2 weeks we'll make like to use the brace without any flexion, sir.
Right.
So we'll make him like prone flexion. We'll start by second week. After second week,
Okay.
so we'll ask him to walk with walker without any non weight bearing with brace for 3 weeks, up to 3 weeks. So after that, we'll remove the brace and ask him to walk without any brace but non weight bearing.
Okay. So what is the logic? If patient keeps
So if
wearing
it
the
is more than
brace,
3 weeks, so some patients may develop like stiffness. So
okay.
so we'll tell them like use do the prone passive flexion
So
but
the
non weight
patient
bearing.
can, yeah. So what I found, if you ask the patient to remove the brace, patients usually take a liberty and they start early weight bearing and all those things. Is it in your cases or just this is my experience?
Yeah, only one case actually. We like he fell down and he came after 3 weeks. So, but in all other cases, it's advantage. Like we got flexion by 6 weeks, like almost 130 degrees, sir.
And any incidence of DVT or calf tightness after arthroscopic PCL level fixation in your study or in your experience?
No, one case we had injured popliteal vessels. So in that case, actually what happened is that is short obese female. So it took around 2.5 hours. So in that time, that while passing the Wisinger rod from posteromedial to posterolateral portal, so my assistant hit the thing. So it hit the popliteal vessel.
Okay.
So after that, after that thing, one good thing is every case after removing the tourniquet, I'll check the pulse and put the probe and we'll go out of the OT for any PCL avulsion cases. So
Yeah.
in
So
that case, like yeah, before only like we were doing like that. In that case, so we like in what just shifting to the post of word, we detected that one, and we again shifted and we called vascular surgeon. He repaired.
Sir,
okay. Good.
I have one question as Dr. Chirag sir started. Do you regularly do any ultrasonographic studies or vascular studies for your popliteal vessels before taking up PCL as a regular thing? And what is your take, or how many times do you find any vascular compromise in PCL avulsion cases?
No, for all multi-ligamentous cases, we will take color Doppler. If any suspicion is there, CT angio. For isolated PCL avulsions, no. So in this case, after shifting to the post-op ward, the patient had toe movements, but pulse was almost not palpable. So we called radiologist and we did the color Doppler. It was monophasic. So we called the as on table, we repaired. So that within 4 hours it was good. One case of popliteal artery injury.
Okay. So I think it goes well. If there is no any other query, we can move forward to the next lecture or next presentation.
Next case presenter, I think Dr. Vikas
Yeah.
Kapoor is still not here.
Yeah, Vikas are not yet joined. So next case presentation we can start.
Can I present?
Number 1. Yeah, Dr. Sharad KR.
Yeah. So good evening, everyone. I am my screen is visible now.
Yes, sir. Make
Yeah,
it
yeah,
in.
you are visible and audible, sir.
Yes. Okay. So
Please
my
change that to slideshow, sir.
so I'll start the. Okay. So is it better now?
Yes.
Yes.
So my presentation is with the anatomic PCL reconstruction, PLC reconstruction with multi-ligament injuries. So we all know that popliteus and popliteal fibular ligament provide restraint against tibial external rotation at higher flexion angles. So and popliteus is also secondary restraint to posterior tibial translation. So this is the popliteus and popliteofibular ligament, and the forceful hyperextension with external rotation and varus is the cause of this PLC tear. And patient may realize sensation of instability and posterolateral pain, and most unstable near full extension, knee buckles into hyperextension. So most important is knee buckles into hyperextension and there is external rotation. So they may have posterolateral ecchymosis, and varus test is positive, and dial test is positive, and external rotation recurvatum test is positive. So missed posterolateral corner injuries is a common cause of failure of ACL and PCL reconstruction. So this acute injury is less than 3 weeks. So and there is a tunnel coalition of ACL reconstruction with PLC two tunnels of popliteus and LCL tunnels. If we are not careful enough to see the tunnels of ACL, we have to put the ACL tunnel and then keep the scope in the tunnel and then do the two tunnels of popliteus and LCL. So with that, I am starting this case video. So you can see that there is a posterolateral, there is instability and hyperextension and varus test positive. This person had ACL, PCL, and PLC reconstruction. So as described by Laprade, the most of the PLC reconstruction I am doing without tourniquet. So here, this is acute case. As I am pulling the LCL, I am able to see the attachment of LCL. This is the common. There is a torn biceps femoris. We have this is the biceps femoris which is torn, and where the white structure is the LCL. You can see the LCL is avulsed. I am able to pull the LCL from the fibular head. So here, I did ACL and PCL reconstruction day before, and then I did PLC reconstruction. So for PLC, I took allograft and popliteus, peroneus longus. Allograft, I got allograft endoachilles. And here the fibular tunnel, we did fibular tunnel, and whole throughout the procedure, knees to be kept in flexion, and soft tissues below the knee should be. We have to palpate the with the finger the posterior aspect of the knee. So this is the tibial tunnel. After that, we pass the passing sutures. Then these are the tunnels for the popliteus and the LCL. In this case, we did LCL reconstruction and also LCL reattachment. Here, popliteus was also avulsed. we did popliteal reconstruction, also popliteal reattachment with the anchors. So the distance between the popliteals and LCL is about 1.2 centimeters. So we were able to measure it and able to reciprocate the same thing. First thing is to fix the popliteal and LCL in the femur. Then popliteal should come through intra-articularly through the loop. Then popliteal, then LCL from the fibular head. Then both of that to be taken from the back to the front to fix it into the tibial side. Sometimes we check in the C-arm, but most of the time C-arm is not required for the Laprade technique. So with the finger to the posterior side and knee in the flexion and see the ridge and the tibia posteriorly, we were able to do most of the Laprade anatomical PLC reconstruction. In this case, after we fix the both popliteal and popliteofibular and LCL, we reattached the LCL and we repaired end-to-end of the biceps femoris. And we have to fix the popliteal, that is LCL, in about 30 to 60 degrees of flexion, 30 degrees of flexion, neutral rotation and valgus stress. And in 60 degrees of flexion, we have to fix the tibial tunnel. So here we are using the metal anchor with the needle. So we reattach the LCL also after we did the reconstruction. So here we did ACL, PCL, and PLC. So we were able to get into, this is the final video of after repair of all of this. This is the LCL. We are able to see LCL, popliteus. So then this is the picture I am seeing him after 1.5 years of this surgery. He is able to walk for about 5 kilometers, and he claimed the Tirumala also. So we did all the three. So this is another one, ACL with PLC. So again, ACL with PLC, as I was discussing, we have to check the ACL tunnel and then do the ACL tunnel. Here we use the peroneus for ACL, semitendinosus for LCL, and for popliteus and popliteofibular, and for LCL we use gracilis fiber tape. This is the postoperative. This is one more implant with ACL with PLC. So he had a previous tibial plateau fracture with the varus thrust positive. With the PLC and ACL, he had instability. He had got operated this about 5 years before. We did implant removal and simultaneous ACL and PLC reconstruction. With the same implant removal incision, we could do the PLC reconstruction and ACL reconstruction. So this is the, and for the tibial side, we used suture button here. And this is another one with PCL and PLC reconstruction. So double bundle PCL with PLC reconstruction. So thank you for your kind attention. And I invite you all for this Bangalore knee conference in November 9th.
Thank you, sir, for the very elaborative and very detailed presentation on PLC reconstruction. I think there will be a lot of questions on this. Dr. Ravi, do you have any question? We have received few questions.
Yeah.
Yes, sir. So, what is what are the protocol for multi-ligament, sir, for you? So if the patient is having more than 3 ligaments, then what's the protocol like? You want to reconstruct like PLC first?
So most of these multi-ligament, whichever is either PLC, PCL, or ACL, if it is 2 ligament, PCL and PLC, or ACL and PLC, simultaneously
Yes.
we do procedure in the same sitting. If it is 3, like ACL, PCL, PLC, because most of this will have meniscus tear also, we will be doing meniscus
Yeah.
repair. So it will take long time. So if it is more than 3, like ACL, PCL, PLC, most of the times we do staged. Like today we do ACL, PCL, and meniscus, and tomorrow we do PLC, because it will take 4 hours, 5 hours. But simultaneously it can be done. But we follow like if it is ACL, PLC, or PCL and PLC, we do simultaneously, means same sitting. If it is 3, we do 1 day gap. So like this.
One day.
So that's what we are doing. And if it is ACL, PCL, PLC, we try to get the allograft, and because most of the times peroneus, peroneus and semity and gracilis we can use for ACL, PCL, ACL and PLC. But if it is third ligament also, then we have to get allograft or other side ligament. Sometimes we did quadriceps for ACL and peroneus for PLC, peroneus with gracilis, and PCL with a semity. So this type of permutation combination we are doing. So any other thoughts, any other experiences we'd like to know?
Okay. So
May I ask question?
usually
Yes,
Please.
yes, please.
Yeah,
Please.
Dr. Sharad, nice presentation and
Thank
nice demonstration.
Thank you.
So the question is, what is the sequence of fixation of the ligaments? The first. And second, from where do you get allograft and what is the cost of the allograft?
The sequence of the ligament fixation. So first thing is we have to, if at all we are doing ACL, PCL and PLC, first thing is to put the femoral side button for the ACL and PCL, and keep the ligament without fixing the tibial side, and then femoral side popliteus, and then femoral side LCL. First we finish the femoral side.
Okay.
Then we come to LCL in the fibular side about 30 to 60 degree. Then we fix the tibial side, and then we fix the ACL and PCL. This is the sequence we are following.
So you fix the PCL last, or you said you fix first PLC, then ACL, and then PCL?
PCL.
Is it?
Yes.
Okay. So usually what I prefer, I fix the PCL first.
Okay.
Because the tibia sagging is very gross in PCL, in multi-ligament injury, along with the ACL, PCL, PLC. So PCL first, then posterolateral corner, and then ACL. That is what I follow.
Yeah, we can. But this I'm just telling in general. First, we are going to pass the graft from the femoral side, then fix the LCL and popliteus. Then we can fix the PCL. Yes, if it is in the PCL. But Laprade recommendation is to fix the fibular LCL, then fix the tibial side, then fix the PCL. That's what is the.
Okay. Fine. So I will have to search the literature again. Thank you.
May I just add on?
One more thing.
Chirag has pointed out this properly, because PCL being the most central structure, so many of the literature suggests that if you fix the PCL first, it will also correct the sag, and it will make a neutral position, and it will help to fix the PLC in proper position.
Okay.
The most central structure in the knee.
Yeah, and the second question was about the allograft.
The allograft I get from MS Ramaya.
Okay, and how much they
are
how much
charged?
they charge?
20,000.
20,000 per graph. So can
Yes,
we import in Gujarat from Ramaiya? Can we ask them to provide the
yeah,
allography?
surely they'll give. What you have to
Is
do
there
is
any formality?
there is a website. There is a website. We have to go to the website MSRALC and check the available graphs.
Okay.
What are the graphs available? There will be like tendinochilus, there will be semity, there will be some other ligament. So it will be there. So you have to check the available graphs, and there will be length of the graph, thickness of the graph will be written on the website.
Okay. Okay.
You have to select that, and you have to place the order. So they will
So,
send it.
okay. And it is approved by government?
Yeah, yeah.
Okay.
It's
Good. Thank you for the information.
thank you. Thank you.
Good.
Sarath sir,
Yes,
in your first case, you have shown that even after you have reconstructed both the popliteus and the LCL, at the
yes,
end
yes,
you have put a suture anchor and repaired the LCL, avulsely.
yes, yes, yes.
Why so? Because you have already reconstructed the LCL and popliteus both.
Because it was just 3 days old injury. So I thought, let me give one more reinforcement for the natural ligament also. So for that purpose, I put the
Okay, so in any such other cases, not in this type of
yeah,
cases, if you find the LCL being avulsed and
yeah,
in a fresh scenario,
yeah.
so you repair them with an anchor,
Yes,
especially in a
LCL.
young patient.
Yeah, LCL many times LCL avulsed from femoral side, fibular side LCL will not, nothing will happen.
Yes.
Fibular side LCL will be very taut, and we get confused if LCL is torn or not many times. And fibular side, when we pull with the artery, it will be look like a normal. So we have to check the femoral side for the laxity. Even with the isolated LCL test also, sometimes fibular side it is normal, but femoral side is our or it is lax. Like how we see ACL, which is sometimes looks in the MRI normal. When we try to probe it, there is no attachment in the femoral side. Similarly, femoral side LCL, there is no attachment. So we can, if there is a very clear bony avulsion, we can reattach it. That's what is the thing. Otherwise, there is no role as it was there. I don't want to cut and remove it, or didn't want to leave it like that, like floppy. So we will as well fix it. And as bicep femoris were also our torn, we fixed end-to-end repair. So that's what was done in that case.
Okay, so you operated in this patient on day 3. So
Yes, yes, day
in
3.
this type of multi-ligament injury status, when the
Yes,
knee is very much swollen, and
yes, yes.
so what is your advice when to operate in acute
So
scenario?
all this in this there are 2 cases acute, 2 cases late. So apart from this, many of these cases we do acute. There is no problem.
Okay, so you have
No
not
problem.
faced any like stiffness or arthrofibrosis.
No, 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 no problem. No problem. No problem.
And another point is that because this PLC injuries is the one of the commonest thing that is being missed. So this question is asked from our junior colleagues that how to make things, how you detect in your OPDs, because
Uh,
sometimes these patients are being very missed because MRI are often misleading. They don't
yes,
give you
yes,
the
yeah.
point.
MRI in PLC is always misleading. MRI is PLC is always misleading.
So
So
how
we have to check the
Sir,
varus
please.
thrust, yes, varus thrust gate, and then we have to check the drive-through sign. And many times popliteus is intact, but LCL is torn, and there is the excessive external rotation of the tibia, excessive external rotation of the tibia, and there is hyperextension of the knee. So these things point towards uh, the possibility of another ligament tear, which is not clearly described in any of the MRI. So then we have to think of PLC.
do you
So
suggest
one
any
one more question, sir.
Yes, yes,
trace X-ray views in these cases?
yes. What?
Trace X-ray.
Stress X-rays? No, 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 no. There was clear this thing laxity. No use because it is very clear. It was very clear. So we didn't use because it was clinically there was so much laxity, so much instability. That's why not used.
Okay. Thank you, sir. Thank you.
Thank
I
you.
think our
Sharat sir, one more question.
Yes, yes,
yeah, Dr.
Like,
Ravi.
yes.
so your experience with the allograph, sir, any like infection rate or
No.
any laxity
No,
after?
no problem. What I do, my thing is, whenever I'm using allograph, I use fiber tape.
So you internal brace it.
Internal brace. Yes, yes. No infection. No infection.
Nothing, sir.
Yes.
Okay.
Thank you, sir. Thank you so much.
Thank
I
you.
think we had a very great.
Thank you, Ias, and thank you, Dr. Naresh, and others to giving me this opportunity. Thank you.
Thank you, sir. Great presentation. Thank you, sir.
And we can see and very welcome to Dr. Vikas Kapoor, sir. And sir,
Hi, Arnab.
hello, sir. So we are all eagerly waiting to hear you, and we're happy that you have joined. So over to
Good
you now.
evening, sir.
Good evening. Naresh, thank
Yes.
you very much. And Arnab,
Thank you very much, sir.
because it was a terrible time joining Zoom today. Never had so much of a problem. So thanks for helping me out. So I'll just share my, shall I start the screen sharing?
Yes, sir. Please.
Yeah, please, sir. Please go ahead, sir.
So I think this is my presentation. Can you see something on screen? Is my screen there?
Not yet, sir.
No, sir. Mm.
But I have started screen sharing, I believe. Okay, now see.
No.
Just a minute. The share option is not coming. It's showing.
There will be a
The,
green button in the downstairs, sir. Share
no,
arrow.
but it is showing the cancel. It's not showing the share. So choose which, what to share with. Yes, Naresh.
Yes, sir. Now it's coming. Sir, unmute yourself.
Sir, please unmute yourself. Vikas, sir.
Yeah. Are we okay now?
Yes, sir.
Yeah.
Yes, sir.
Right,
You are
sir.
So
clearly audible and
it's
visible.
yeah, it's a very comprehensive topic which we have chosen today for
Sir, you
discussion.
have minimized it.
Have I?
Sir, yeah. Very good, sir.
I'm okay.
Yes, yeah, no,
Can
no,
you?
no. Okay, you
Okay.
can continue.
So
Yes, sir. Please continue, sir.
the cuff tests, these are standard long-term classifications which we use, and of course the geometric classification by Davidson, the textbook classification with crescentic trays, uh, type 2 tears which are the longitudinal L or U-shaped tears, and then there are massive contracted tears which they are according to them is more than 2 to 2.5 centimeters, but for us the massive tears are usually much bigger. And of course the fourth was very vague, cuff tear arthropathy. I think there is a large number of work done nowadays, and this classification may be just a very basic one to hold on to. So Cofield kind of gave it the large tears to more than 5 centimeter massive tears in the width, and Gerber also classified by saying that there are more than when there are two tendons, they are the massive tears or large tears. So either supra or infra or superior subscap and supra, etc. So basically, massive cuff tears, the consensus study was that they can be classified as the massive when you have retraction to the glenoid rim or 67% of exposed GT. So we traditionally in our country see retraction to glenoid rim as the tears which we call massive or large tears. And exposure of GT is usually what we see by the time the patient comes to us quite significantly. So for us, I think we may have to be working on some Indian classification of massive tears which we are repairing these days. Other classifications are, of course, as I said, involvement of two or more tendon and supraspinatus with superior subscap, entire subscap with supraspinatus, supraspinatus upper part along with infra and supra separately type D, and supra onwards up to teres minor type E. So these are more comprehensive classifications which tell us about how much and what are the force couples which need to be repaired. Now, what are the pre-op clues? I mean, nowadays it's about whether it is repairable tear or not repairable tear, where the traditional Gautier stage, where you see fatty sort of degeneration of the muscle, it is fatty infiltration which is far more significant when it comes to repair of the tendon and the muscle holding out, because fatty degeneration still is workable. You have a workable amount of muscle in it, but if it is infiltrated by fat, that means this is very, very poor prognosis. Fat grade, of course, it's about where how far down the tear is. Stage 1, 2, and 3, as you can see, diagram is self-explanatory. And of course, the tendon length, this is a complex classification, which I usually don't follow. The strategy in management is what type of patient you are operating, whether it is a young patient, an old patient, a fresh tear, an old tear, and therefore you have to prognosticate the patient. Appropriate surgical technique is important. The skill of an arthroscopic surgeon. It's not necessary that you have to be a super arthroscopic surgeon to do a cuff repair. It has been traditionally done open. A lot of our colleagues who do arthroscopy still do a bit of open surgery, and a lot of shoulder surgeons practice open surgical cuff repair. So nothing is wrong or sacrosanct as far as surgery is concerned, and surgical technique is obviously important. Then it comes to type of fixation, single row, double row. Tissue mobilization is extremely important. You have to really kind of scrape through up to the at least 2 centimeters around the glenoid in order to pull the cuff back into its reasonable position. Sometimes what happens is that the cuff does not really reach the exact tissue footprint, and you have to medialize the cuff. If you are medializing the cuff, then of course you have to optimize the biology. You have to make sure that you are able to support the cuff and the strength of the cuff is good enough for doing this surgery. Factors which improve and influence the outcome. Adequate subacromial decompression is important, because if you are not decompressing the cuff well, you actually might end up leaving the causative factor of the cuff tear. So you need to have a good decompression. Maintain the integrity of the deltoid origin. So if you are doing a sort of anterior acromioplasty, or if you are doing sort of short, a small incision in doing your cuff repair, make sure you don't really harm the deltoid. For most of the arthroscopic surgeons, this is not a problem, and most of us really don't really bother, because deltoid origin is completely well taken care of, and that's one of the best advantages of arthroscopy. So mobilizing the torn tendon, as I said, from the GT, these cuffs sometimes are presenting extremely late, and you have to make sure that the tendon becomes extremely mobile and tent-like. Any extra uh, tension on the tendon and muscle interface can lead to retraction again, and the tear at the muscle tendon interface. Tendon might remain attached to the bone, but it may tear again from the muscular junction. So repair the tendons to the bone well and make them sit very nicely, leaving minimal dog hair if possible, and try to make sure that they are repaired with the correct force couple. They are pulling in the right direction so that there is no undue or unnecessary pressure on these tendons. And there has to be a supervision, which kind of post-operative rehab. It is quite dependent on education of the patient, on the type of people you are treating. The athletes may be super extremely compliant to your rehab, while people who don't really understand or have a poor level of understanding of their problem may actually not do so well. So there is non-operative management for people only who cannot take the surgery or are unfit. Then, of course, biceps tendon redressal by tenodesis or tenotomy in case of irreparable cuff tears. Rotator cuff repair may be a partial or a complete repair. And partial repair is in the case where you actually want to still save, the patient from and has a reasonable articular surface, and you have a cuff which cannot really come down to the right place. So you augment and do the partial repair. Superior capsular reconstruction with fasciolata graft, with biceps patch, or even with sometimes, you know, other tissues, bovine tissues are done. We have fasciolata and we can really use it if at all it is needed in patients whom we do not really plan to do a reverse shoulder or some other surgery. Tendon transfers in younger patients where you have an irreparable cuff tear, where you do the traditional tendon transfers like light dorsi, pec major, and traps. And of course, the reverse shoulder, which has become a kind of panacea in cases where you have irredeemable shoulder with very bad arthritis and absolute acetabolization of the humeral head. So the goal is to remove the pain generators, convert three, two, or one tendon tear, and balance the force couple. Extremely, extremely important. Just tying up the tendon to a place in the bone is not cuff repair. You have to have an idea where you are actually putting your tendons and how they are going to pull the in which direction, and that is going to determine that whether the re-tear is going to happen or not. Also, it is going to determine whether the shoulder will be stiff or not. Also, it will determine whether this is going to last or not, even if you have medialized it slightly. Uh, Humeral head depression is an option. I mean, you can use capsular. This is what capsular reconstruction is all about. And the other things like balloon, I don't have an experience. It's all in literature, but RSA is definitely an option. And rotator cuff repair with patch or allograft and tendon transfer, as we have done, as we have talked about, to restore the length. Well, non-op treatment is absolutely rare nowadays. We do it less and less for patients who are extremely old and are able to have enough movement without much pain. It is the pain that we are treating most of the times. Some amount of weakness may be accepted by the patient if they are not very painful. Debridement and subacromial decompression, as I said, with biceps tendon, tenodesis, etc. Again, if we want to do a salvage surgery, it may be an option where you are not able to repair and you don't want to do a kind of a reverse shoulder. Well, the cuff repair improves the clinical outcome. Repair must be strong enough to maintain tendon reduction during healing, and traumatic tear should be repaired early to prevent traction and scarring. Both arthroscopic and open repairs are acceptable. So don't get over kind of subdued by thinking that open repairs are not anymore done. They are done by a large number of surgeons. Although we as arthroscopic surgeons have been practicing our type of repairs for almost 1.5 to 2 decades. Care should be taken to avoid over-tensioning of the repair, and it has been shown that there is a low retear rate in double row cuff repairs, but at the end of 6 months or 2 years or 1 year, I think a well done single cuff repair is as good as a double row repair. It's a choice of a surgeon, but of course, in the initial days, definitely as a surgeon, I like doing the double row cuff repairs, and that has stood the test of time in initial testing times. Well, we come down to our interesting part of the talk now. A case of right shoulder pain for past a month with 60-year-old male, an overzealous gentleman, and you can see a large cuff tear which is up to the sort of GT. And as you see here, is the video playing? Can everybody see this?
Yes, sir. Playing.
Hello?
Yeah, playing,
Okay.
sir.
So as you can see, this tear which I did was a very large tear. It's sort of from subscap edge to you can see the biceps tendon, and the tendon seems to be reasonably okay, not too bad, and the tendon is just getting covered by the supraspinatus. And as you see here, I am the first step is to do a biceps tenodesis. This is a pretty active gentleman, and the tendon was quite good. But since the edge of the tear was absolutely close to the biceps tendon, this is one of the ways of doing tenodesis. You can do several ways. So here a normal anchor was used. It was not a swivel lock anchor. So I took it with a bird beak. I try various techniques. I do it in 10 different ways. There are 10 different ways to bell the cat, and I've been doing this biceps tenodesis in different ways. Whatever comes to my hand, you just have to stick it down to the place as you can see. So you do a nice tenodesis and then you shave away the rest of the tendon. So with tendon out of the way, a lot of cuff gets mobilized. It makes it very easy. And this is with the help of a scorpion passing the sutures from the cuff. In fact, I think I have taken the sutures from the cuff with the help of one of these extra sutures from the biceps tenodesis anchor also. And here you see I'm medializing the cuff a little bit. I'm not exactly putting the first anchor in the footprint. It is going slightly at the edge of the tendon, the junction of the cartilage and the bone, because even after mobilization, it was becoming quite tight. So once you have done your first suture, the other part of tendon, which is the posterior part, was more mobile. So I tried to pull it down, and the second anchor which was placed in a slightly more posterior position, which you will see just now. So first of all, the best part is and the second anchor, as you can see, this is a different anchor. The previous ones were all suture anchor. This is a PMMA anchors, I think, and so these are all double loaded anchors. I usually put two double loaded anchors most of the times, and most of them take care of the massive cuff tears because you're able to pass in at least four well placed sutures. So, therefore, there are 8 threads going into the anchor and to the cuff. So, this technique which we are seeing here is a suture bridge technique. This is we put in the sutures, and after we have put in all the sutures, we tie the knots. This is going through the infraspinatus. So this had a supra and an infra. As you can see, it is going right at the back of the shoulder through the infraspinatus. So this is pulling the infraspinatus, and you have to be absolutely perfect in your positioning of these threads so that they pull in the right direction and do not cause any tension. And once you do that, you come back, and after you've done, this is how we do the second row repair. This is an omega anchor, if I am not wrong. This is a, yeah, this is an omega anchor. I've taken it from the first uh, uh, anchor on the previous first row, and then it goes in and it gets locked there. This is second anchor, I think, which I am placing is a swivel lock anchor. And this is the second row, second anchor repair. As you can see, there it goes. So once you do all this, you have been able to actually do a decent job in this. As you can see, the cuff repair. This is a complete repair and well rotating shoulder. And as luck would have it, this gentleman did a reasonable job. At 6 months, his cuff is holding very nicely. Of course, this cuff is holding nicely, but after actually this particular surgery, this gentleman was a poor rehabber, and therefore, even though his cuff was extremely well maintained, he had a bit of scapular movement, but he was able to do everything he wanted, and the pain went away. So he is still doing reasonably well, and it's been almost 2.5 to 3 years. Second case is a 5-month-old trauma. Again, you see a massive tear, and the tear is retracted right up to the glenoid. Uh, Similar surgery, I'll not really push much on this one. As you can see here, it's a bit, yeah. So again, this is a similar type of surgery, but this cuff is easily or more mobile. So it is coming very nicely, and it is coming actually quite covering it very nicely. This is a much better cuff, much more mobile cuff. Why I wanted to show this case was the previous cuff was not mobile, probably, and that led to the dysfunction he had. Look at this double row repair. This gentleman actually did not even take a sling after 3 weeks and had a fantastic result. And the double row really sort of makes you feel very comfortable after doing this repair. Adequate subacromial decompression, as you can see, nicely repaired tendons at the right place, good coupling, and look at the result at 8 months. So this gentleman sort of had a much better result because, as you can see, if your cuff is mobile, it is attached to the right place, they are much better patients. So one of the factors which, as I was discussing in cuff repair, is how tight your cuff is, how old your tear is, and how well it has been brought back to the footprint. It all decides on what happens to your patient. And this is the follow up beautifully covering, and this cuff has healed well. Now, the other technique which we do nowadays is the speed bridge technique. In this, we do not really, this is also a pretty large cuff tear. The biceps tendon is quite bad. So, here in this case, you may choose, I don't know what, I think you can choose to repair, or you can actually just remove the tendon. You can just do a biceps stenotomy in these cases. So here, this is in speed bridge technique, you actually use 4 swivel lock anchors. And with the help of 4 swivel lock anchors, you don't really have to tie the knot on the cuff. You just pass the suture tapes, which are attached to the set of these anchors, which are given to you by the commercials. And there are 2 threads on 2 sides and 2 tapes attached to each anchor. And once you do this, you just pass it, and then you crisscross the suture passes which have happened through the cuff, and then straight away go and lock it at the second place, as you can see. So there was no knot tying. There is no knot tying done on the cuff because the tapes have a much larger stress distribution. You are quickly able to bring them back, so you don't really waste time doing a knot tying on the like a suture bridge. And speed bridge, I have done some cases, and they seem to be holding up very well, and the patients are quite happy. And they have shown to have, if the cuffs are good and mobile, then this is a safe technique to use. But in cuffs which are not very mobile and you are trying to medialize, speed bridge, in my opinion, may not be, because they don't really cover the footprint. So if your cuff is very tight and you are medializing it, I would still recommend suture bridge. But if you have a very mobile and nice cuff, which is absolutely covering and coming up to the GT, you can use a speed bridge technique, gives you much faster and a better coverage. and a good result too. Just a variation in technique, as you can see again. So you have four swivel lock anchors with tape on the first row anchors, which you use in order to complete the repair. Now, partial repair, only a part of massive cuff tears are repaired at the tuberosity, and it can improve the force couple and help the shoulder from migrating up. Repair with tissue augmentation, this is what is happening nowadays. It's an expensive procedure if you use allograft as a human dermal or synthetic grafts, but it is a procedure which can be kind of useful if you are using autografts like biceps tendon and fasciolata. Indications are large tears, again, multi-tendon tears, chronic tear with poor tissues, re-tear or revision scenarios, and to promote healing. Augmentation of tear is with can be mechanical or biological, by patch, by scaffold, by, of course, commercially available grafts and the xenografts. SCR, as I discussed, is done with the help in cases where there is patches are insufficient to give the structural integrity. SCR has potential to restore and rebalance the force couples. It's valid and viable joint preservation option. Fasciolata is what is easiest to use. Long head of biceps, if you can smash it well, you can use it. This is a schematic diagram. Uh, this is the technique. The only problem is it is a relatively thin graft, and it has needs the incision large enough to sort of harvest, and there is a some amount of donor site morbidity. So this is how you do this. You can actually, this is an acellular dermal graft. This is not, this is a commercially made graft. We don't have access to it. As you can see, these are the things which define it. This is a thickness is 3 millimeters, etc. You just take it in and you put it on the cuff at the place so that it augments and promotes fibrosis and healing. Basically, it is promoting the fibrosis and it is promoting the healing, and that fibrosis helps in tendon bone sort of integration. This video is of fasciolata augmentation. As you can see, again, it is a huge, massive tear, and again, a very, very difficult, tight tear to repair. And once you've done it, you kind of again try to pull as much as possible, then pass your sutures and try to pull it. Then again, you medialize your tear as much as possible. After you can just putting it on the edge of the tendon, the uh, uh, interface between the cartilage and the bone. So first you do a repair, medialized repair of the tendon as much as you can bring it close to the bone. Then you take the fasciolata. The fasciolata is taken based on the length, and you can then put in these four passing sutures. After that, you have to pass it in carefully with the passport cannula, which goes in, and then you place this, and with the help of two probes or two, what do you call, suture passers, you try to just place them in a proper place and first tie the sutures on the between the fascia and the tendon, and then like a double row cuff repair, you go ahead and do a repair of that particular graft at the edge, at the end of the, so kind of do a double row cuff repair. Long head of biceps tendon rerouting technique is what Kim et al. Have propagated. You take the biceps tendon, do not cut it out. You fix the biceps tendon, medialize it, you bring it towards the head, between around the near the GT, away from its exit into the canal. Pull it out a little bit and bring it more superiorly and fix it to the humerus, and that biceps tendon kind of forms a scaffold on which you can tie the rotator cuff. And this technique has shown some good results in some cases where you have large tears which you are not able to exactly close the head completely. So you use the biceps tendon, which is still attached to the glenoid, and you create a false attachment at the middle of the head of the humerus where the cuff is not able to come, and then repair the cuff on both the sides with the biceps tendon. Bicep smash technique. This is an instrumentation provided by Arthrex. You take biceps and take it out, and I'll show you this demo. They have sent this video. So you can use this technique, take out, it's an interesting way. You can do a biceps tenodesis outside. We do open biceps tenodesis for years. We have been doing this for a long time, and we do it in cases of shoulder arthroplasty also. So same technique you can try in the bicipital groove. Do it, and then you have a long biceps tendon with you. This long biceps tendon, they provide a particular instrument which you can smash it with, and it creates a graft, a flat graft out of the biceps tendon, which you measure. And then with the same technique as you use the fasciolata graft, first you tie up your cuff, and then you pass your sutures, four sutures at four end into the smashed biceps. And with the help of two of these suture passers, you can actually push it and just take it into the shoulder with a passport cannula, and then you tie it first on the edge of your graft, and then the other part of the suture you pull it down, and you can do a similar cuff repair type surgery which we showed with the. And sometimes this acts as a biological graft to augment the cuff if it is not there to cover the rest of the area. Here you can see the second row going. So tendon transfer again is open surgery for young active patients with minimal glenohumeral arthritis complaining of weakness. A surgery favored by people for long, long time in our country when this was not about cuff tear. It was in other things like polio, etc., upper limb weakness. We have had fantastic surgeons doing this surgery for various other indications. At last, we come to what is in vogue nowadays. A lot of shoulder surgeons, people like us who have avoided this surgery for a long time. In last 10 years, there has been a resurgence. We are doing it much more. We are much more bolder in doing this surgery. In earlier, it used to be in 80s, then it came in 70s. Now, in 60s, it is becoming a surgery of choice in patients who are extremely painful, and they do need some relief even for 10 to 15 years, although of course after that you don't have many answers. So I would rather reserve it for patients with extremely bad shoulder, very, very painful, begging for help, and where there is no cuff left for years, and have uh, got Hamada grade 3, and when other interventions have failed. So this is one of the cases, as you can see, of one of my patients with very, very bad shoulder, and did not have a cuff. As you can see, the shoulder has migrated up. The MRI pictures show nothing, and this is the surgery. Uh, Straightforward. Actually, I do this reverse shoulder by a deltoid splitting approach. I do a lateral approach. Most of the surgeons, they do prefer. Uh, Most of the surgeons, they prefer doing it by deltopectoral. But for me, I think when I've decided on a reverse, the end on view for doing this surgery is very, very good for the glenoid, and the orientation is fantastic. So for my reverse, I do a lateral approach, and for my totals, I would straight away go and do a standard deltopectoral. That works in my hands. It's a technical issue. All of you have your own choices, and it's a great way to relieve the patient of pain after doing after having a massive irreparable cuff tear. So once you do this, these are the patients who are extremely, extremely happy. 6 weeks, and they are really very, very relieved. So these are painful, painful tears, and these are the patients who need a lot of your help, and they do really well if you do it in good and properly indicated cases. Thank you. I think we have covered a lot of things. I hope that things have been able to sort of cover most of the things which are needed in basic tenets and management of rotator cuff tears, which starts from large tears and goes up to the replacement surgery. Yes, Naresh,
Yes, sir.
thank you.
Thank you so much. I think everything was covered. So if there is any question, Dr. Naresh, I think sir has elaborately covered all the points.
Yes,
Yes,
sir.
sir. It's
Sir, very elaborate talk on rotator cuff, large massive rotator cuff tears.
I warned you it will be a long talk. So only Zoom was playing the spoil sport in between. But I
No, no,
thought
sir.
that this is an opportunity to put it on record. A lot of learning has to happen, and I think this what IS1 we are doing, this kind of one proper comprehensive talk on each topic. If it is done, then a lot of our younger friends probably really won't need to go around looking for step by steps. They have everything covered. So I tried to do that as much as possible with illustrative examples. Of course,
Yes,
there are questions which may be welcome if people are ready to ask.
yes, sir. Very well kept and
yes,
very
sir.
well
Good evening, sir.
presented. One more takeaway from this, I have learned personally as a young starting
Yes. Hello.
Yeah.
shoulder surgeon that
Yes.
don't be scared to open the shoulder and do the surgery. That is a very good point you have raised. Second thing, regarding the large massive cuff tears, medialization, in my view, is still relevant rather than going for big surgeries. What is
Yes.
your take
So
on this?
yes. So if you have been to international shoulder meetings, especially Buddy Savoy, who is, I think last year he was the president of American Academy of Orthopedic Surgeons. So he regularly comes to La Fosse meeting in France, and
Okay,
he is one of those people who never talks about. He says that all the cuffs can be repaired. For
okay,
him, it is about medializing the cuff, and a lot of surgeons in America, I think it's a matter of continental issues,
yeah,
So a lot of practice of people and is that you try to cover the head even if you medialize so that at least you are able to, if you are not able to balance the force couple also, if you give the patient 10 more years or 8 more years before the patient really has a bad situation going forward for arthroplasty, there's nothing wrong in it as long as patient A has pain relief, B has reasonable function, and is able to pass time and reach a certain stage in life where he needs surgery like a replacement or for a massive cup tear. I think that also is a very relevant point in treating these tears.
uh, one more question, sir. What is your take on the scaffolds recently, which are gaining prominence in the
See, they are
in India?
expensive things. You if you have your bandwidth, if you can do surgeries. Well, if the patient can afford, then my take is that these are all fibrosis causing agents. I don't
Yes.
believe that there is a lot of biology acting there. But
Okay.
if you do a good reasonable cuff repair, if you are like even in the midway at the footprint, and you do some microfractures around that area and try
Okay.
to get some regenerate or PRP and go slightly slow on the rehab. Uh, So you do passive assisted rehab instead of doing active assisted rehab for first 3 to 4 weeks, and then slowly start active assisted work with the patient. They do reasonably well. Well, I cannot say that these regenerative therapies or the patches which are available are out of the window, but we are testing waters. Uh, our friend Dinshaw has done the largest number of these surgeries. Uh, Obviously, there is a huge financial angle involved in it. So it depends on horses for courses, where you are situated, what you are doing. If you do your job well, if you follow the science well, it is just a matter of time when whether you need it or not, and when the results are out, you would come to know in our country. But they are an adjuvant, and you can always use them if you kind of feel slightly insecure and your patient can afford it, and you have it with you in your operating room.
Thank you, sir. Dr. Arnab, sir, any questions?
I think that has covered everything. So, and you asked regarding the recent bioavailable things which are gaining popularity. One thing I just want to know from sir, what is your take on the partial repairs? That in some cases we have seen that we can repair one tendon, maybe two, may not be three. So whether we are doing good or whether we should leave and move ahead to another procedure.
So Arnab, partial repair, I am being very honest with you that there is only one case out of last 10 years or 15 years of arthroscopic cuff repair, maybe since 2012-13, that I remember I failed to completely cover the head. You know, it is not such a difficult thing to do if you mobilize the cuff well. So if you have failed to do it, I did that surgery just because I wanted to avoid a reverse at that point of time.
Okay.
And it was a salvage. Patient did not do too badly. You know, I believe what worked was a large deroofing of the subacromial area and biceps tenotomy, which I did because the biceps was completely gone. That biceps was really very bad. I could not have done a tenodesis, and it would not have helped. Patient was old. Patient was not young. The joint was not very arthritic, but
Okay.
the cuff was not completely coming to place, and it had a very shredded, very difficult pattern to repair. So first of all, I passed the sutures at the I passed the pulling sutures at the apex of the cuff to pull it as much as possible, and then with that suture did repair, and eventually, as much as I could bring, close the this into this, and this part was left, and at that point of time I tried to put the anchor. So basically the force couple was not properly met. That was my partial experience with repair. Otherwise, I don't think, if you cannot repair at all, if you are like only repairing 30% or 40% of cuff, you should be able to get at least 70% coverage, 70 to 80% coverage of the head. Otherwise, I don't think there is any merit. Then you can just do biceps tenotomy, do large deroofing, let patient be pain free, try to rehab. Later on, warn them that after a couple of years, you might have to go for a reverse shoulder.
Okay. Yeah, understood. That's all from me.
Very good take, sir. Any more questions, Ravi Babu, sir? Any questions?
Yes, sir. Sir, good evening, sir. It's a very good presentation, sir. So I have a question. Like in first case, subscap was stayed, I think, sir. Subscap.
No,
So
in the first case, subcap was not torn.
not on.
Actually, I spoke it out in a wrong way. The edge of the subcap, the biceps tendon, the supraspinatus tear started just at the edge of the biceps entry into the out of the tunnel. So maybe anyway, what's your question? If the subcap is torn,
If
then what?
subscap is there, then like inside the box or outside the box repair is your preference, sir, with the massive cuff tears. Like you do first go into the joint, do the biceps tenodesis, then subscap repair, then come subaqueous space, and then the cuff repair, sir. Or you do like outside the box subscap repair.
Outside the box. See, no. Sorry. So my technique would be to uh, do a biceps tenodesis in subpectoral area. Okay. So I don't hesitate to do a open, cut your biceps at the glenoid, take it out, and I showed the subpectoral tenodesis of biceps. So you do a biceps tenodesis at subpectoral area. Again, go back into the shoulder. Then you have a much bigger space to play around with. You can then do your subscap repair inside, all arthroscopic repair very nicely. Your vision is very clear, and it's not such a big deal to. And in fact, I'll tell you, in subscap repair, what I have seen is that a single anchor repair itself sometimes holds very well. One anchor, double loaded anchor for subscap does wonderful job. I mean, uh, so that's not much of a problem as far as I'm concerned. And we start with subscap, obviously. We start with
Thank
subscap,
you.
then come up towards the supra, and then if infra is torn.
Thank you.
Am I okay?
Thank you very much, sir. Any
Yes.
more questions,
Yeah.
Dr. Sharad, sir? Yeah, sir. Sharad sir, any questions? Sandeep sir also joined. Sandeep sir, are you there?
What's happening?
There is no question from my side, but
Is
really thanks, sir, for having excellent.
how is Bangalore preparing for the meeting?
Nice, sir.
We are all waiting to come.
Please, sir. We'll be
We
very.
are
Please come, sir.
all registered and waiting to join all of you.
Thank you, sir. Thank you,
It's
sir.
a very long journey of IAS. We have been part of this great society for last 24 years now. So
Yes, sir.
it's been a long journey, and I'm so happy to see
Thank you, sir.
our IAS doing such a wonderful initiative. Thank you, guys, and
Thank you, sir.
have a
Thank you,
great
sir.
time.
Thank you very
Thank you.
much, sir.
Thank you,
And
sir.
thank you,
Thank
If
Arnab.
there is
Thank
no
you,
any questions,
Naresh.
Thank you,
Thank
sir.
I
you,
will ask
Ravi.
Thank you,
Dr.
sir.
Arnab sir for closing remarks.
Yes.
Thank you,
I
sir.
think today we had a great time discussing two very interesting cases. One is a suture bridge technique of PCL bony avulsion and a very elaborative lecture on PLC reconstruction, especially in very multi-ligament scenarios. And after that, eye-opening talk on massive cup tears, how to do, how to classify, and how to tackle such cases. And we also need to understand the proper role of a good rehab after the surgeries of these cases. And we had a very good session of question and answers, and all the queries has been answered. So we had a very good time discussing academics. So I thank you all who have joined us today evening, and we hope that we'll continue the journey of iOS such webinars in future also. Until then, we wish a very good night to all of you, and thank you to all the speakers. Thank you, sir.
Thank you. Good night, sir.
Thank you,
Bye.
everyone.
Thank you very much, sir.
Thank
Thank you.
Thank you.
Bye. Bye.
We have completed 40 webinars and we are running towards 50. This is
Yeah.
for today.
All
Good night. Bye.